So this is Dr. Alicia Bright. We are going to apply the concept of gas exchange to the disease process of pneumonia, the patient with the disease pneumonia. Pneumonia is, as you know from pathophysiology, an acute infection of the lung parenchyma. That means the tissue in the lung. It does kill a lot of people. It's the number 6 cause of death of people in the United States age 65 or older. It's also been called the old man's friend. A lot of people die of pneumonia when they're suffering from underlying health issues. So, for instance, people whose immune systems are injured by disease or by treatments, for instance, chemotherapy patients, will sometimes develop pneumonia, and it's actually the pneumonia that kills them and not the underlying disease process. So this is an illustration on the left. It's a chart showing the cascade of responses. It's an inflammatory response that happens within the lung tissue, as we said. White blood cells come in to fight the infection. This results in accumulation of debris from cellular deterioration and mucus production, which is part of the response. You can see on the right is an illustration of what happens inside the alveoli. The lining around the alveoli becomes inflamed. The air sacs can become actually congested with a lot of mucus, which then gets coughed out, hopefully. Results in a lot of mucus and possibly airway obstruction. This is just a chest X-ray that shows the density on the part of the lung that's circled. That area should be clear. You see the clear outline of the base of the lung on the other side of the X-ray, but on the side that's circled in red, it's dense. It's consolidated. There's a lot of fluid in there, mucus and swelling, and so that's just what it shows up like on an X-ray. Density looks light, and the darker areas are filled with air, which is appropriate for alveoli. So the rest of the alveoli is okay, but in that right lower lobe, there's consolidation. You can see it on the chest X-ray. Risk factors for pneumonia, of course, our older folks are really worried about them. Anybody who is immune suppressed, if there's been a lot of antibiotic use, this is a risk factor for developing pneumonia, actually. It's another reason why we want to avoid using unnecessary antibiotics. Prolonged mechanical ventilation. So anybody who's on a mechanical ventilator is critically ill. You'll learn more about that in MedSurg 3. Don't worry about it too much right now. We're going to touch on it when we talk about types of pneumonia. Multi-drug resistant organisms. Those are a growing problem. Staphylococcus aureus and gram-negative bacilli are a couple of examples. All kinds of problems out there with these exciting new bacteria that are causing us headaches, or worse. So the different types of pneumonia. Community-acquired pneumonia is what you typically see when someone they're out in the community and they just get run down and then they end up with pneumonia. Sometimes it's called walking pneumonia. That's one nickname for it. These are pneumonia cases which we really can't consider them preventable as nurses. I mean, we try and help people to stay healthy and support their immune systems and have good preventative respiratory care, such as not smoking. But really, these are things that people pick up in the community or develop in themselves, and they're usually treated at home. They might be hospitalized if they get bad, but of course, we just put these people on antibiotics as soon as possible. Aspiration pneumonia is the kind of pneumonia that you have spent probably a lot of time trying to avoid when you're helping people to eat who are on aspiration precautions. You know, aspiration precautions is where we sit everybody up and we sit up the patient and we make sure that they're supported properly so their posture is good. We assist them. Usually they don't get to drink liquids. They have to drink thickened liquids. Anyway, it's all about trying to avoid having them aspirate. Once they aspirate, they can get secretions or foreign foreign substances. For instance, gastric contents. If somebody is regurgitating, they may actually inhale what they've regurgitated. That causes a chemical injury. So, food getting in there, gastric acid, other kinds of fluids, other kinds of secretions, and bacterial, those get in there and they can cause a bacterial infection. Sometimes there is a loss of consciousness that's involved, which is why we would turn an unconscious person on their left side to avoid aspirating. Medical care-associated pneumonia breaks down into 3 parts. Don't worry too much about the details here. The point that I'm trying to make with this slide is that hospital-acquired pneumonia, ventilator-acquired pneumonia, and healthcare-acquired pneumonia, that's the HAP, VAP, and HCAP that you see, those 3 points on this slide. These are all considered nurse-sensitive, meaning there are things that we can do to prevent most of those cases. A case of pneumonia is considered a healthcare-acquired pneumonia if this person has been hospitalized for 2 days or longer within 90 days of infection. So if there's a recent history of somebody having been in medical care and they develop pneumonia, we need to examine that to see if there's something we could have done to prevent it. We're going to talk about prevention of pneumonia in a minute. This is a very important topic because it is considered nurse sensitive. Of course, healthcare-acquired pneumonia up at the top. This is pneumonia that occurs 48 hours or longer after admission. So that's somebody who comes in and they're okay and they develop pneumonia, sometimes after surgery or so forth. Ventilator-acquired pneumonia. When you get to artificial ventilation in your Med-Surg 3 class, Senior 1, you'll talk about ways to prevent ventilator-acquired pneumonia. You will revisit this topic in a different context. So when you take out your stethoscope, you're going to notice finer coarse crackles, bronchial breath sounds, egophony. Remember the assessment that you learned how to do, having someone say E, and feeling for vibrations? This is one of the times when we use that. You might feel increased fremitus, vibrations in the chest wall when you're feeling with the back of your hand. And if you remember how to percuss the chest, this is what we do when we can't get a chest x-ray. So you won't see this done actually in clinical practice very often, but it is a good thing to know how to do. If you are in a home care situation, for instance, and you have someone and you're worried that they have pneumonia, this would be a nice way to assess it and decide how hard you want to push them to get in there for that chest x-ray. Just an interesting little assessment tip. Okay, complications of pneumonia include pleurisy or pleural effusion. That's what I mentioned a few moments ago, that area in the pleural space becomes inflamed and painful. Pleural effusion is when actually fluid builds up in that area. There's so much infection that it starts getting pussy in there. Atelectasis, of course, we know that's when the alveoli sort of collapse. Bacteremia, of course, is blood bacteria in the blood. Empyema, pus. Pericarditis is inflammation of the lining around the heart. If you think about it, the heart is positioned directly between the lungs. If the lungs are inflamed, the lining around the heart could become inflamed. Very severe complications are meningitis, for instance, if the infection spread to the lining, the meninges, the lining around the central nervous system, around the brain and the spinal cord. And then there's sepsis, which we discussed a couple weeks ago, sepsis and septic shock. There's acute respiratory failure. And pneumothorax. Pneumothorax you'll learn more about next semester, and you'll learn about chest tubes. But a pneumothorax is when air gets into that space between the lung and the chest wall, and that can collapse the lung. This is distinct from collapse of the alveoli, which is atelectasis. A pneumothorax means there's now air making less space for the lung to actually expand within the confines of the chest cavity. So, like I said, we put a lot of energy into preventing pneumonia in hospitalized patients or at-risk patients. This is considered to be nurse sensitive, and there are things that we can do to prevent it. Some of these things on this list may surprise you, and let's start out with pain management because it's at the top of the list. Pain management is important, as we've talked about, in post-surgical patients. It's also important to manage somebody's pain, to encourage them to doing the things that they need to do, like coughing, deep breathing, and using incentive spirometer. If you have someone who's in a lot of pain from, for instance, a big abdominal incision, they're going to be reluctant to take those deep breaths, and in fact, the pain in their bodies may prevent them from being able to take those deep breaths that keep the lungs expanded, keep the alveoli expanded, and allow them to cough out the exudate so that they can oxygenate better across that alveolar membrane. So pain management is actually a way to prevent problems for pneumonia patients. Of course, we don't want people over-sedated, but we do need to keep them, we need to keep their pain managed so that they can function, move, get up, deep breathe, cough, etc. Big thing that we do to prevent pneumonia. Elevating the head of bed at 30 degrees and having them sit up for all meals, that's pretty much aspiration prevention. Getting people up and moving, walking, of course, we know about that. It's important. Incentive spirometer is good. And then there is twice daily oral hygiene. There have been studies that demonstrate this really does decrease the incidence of pneumonia in hospitalized patients. So I'm not sure how many of you have brushed your patient's teeth. If you have never brushed somebody else's teeth, I encourage you to go ahead and do it. Try it, practice it someplace, because it is important. Now, nursing assistants often are the ones who are responsible for doing this, and that's good. But as the RN, you're going to be supervising them to do this. So, this may be the perfect opportunity for you to choose the loved one who is most patient with you and practice brushing their teeth. Really, try it. When I taught skills, I used to have everybody bring their own toothbrush and brush each other's teeth. Once you've brushed the teeth of a fellow student, not only are you now best friends, but you're going to be able to get in there and brush the teeth of some perfect stranger who's actually going to be sort of happy for you to do it. Or maybe not so happy, but it's very important. Anyway, back to business. Strict medical asepsis, just keeping down the amount of bacteria that's floating around in the rooms. Of course, hand hygiene. Respiratory devices need to be kept very clean. Suctioning. So you learned tracheal suctioning. We can also do nasotracheal suctioning if necessary. If someone's secretions are building up and they're having difficulty clearing them, this can cause respiratory arrest due to obstruction. It's important to be brave with that suction catheter. If someone is really getting into trouble, we might need to go in through the nose. It's the same procedure as going in through the trachea, but you can go in through the nose and suction out some of those secretions. It stimulates a terrific cough. It is very painful for the patient and very difficult, but then you clear those secretions and they can breathe much more easily afterward. So they'll hate you at the moment when you're doing it, but they'll be grateful when they can breathe more easily afterward. And the last thing on this list is to avoid unnecessary antibiotic usage. There it is again. So what are we going to do? If we're going to do everything we can to prevent the patient getting sick, but once we have someone who's got pneumonia, and this is true for anybody with any kind of respiratory problems, really, this is pretty straightforward. We're going to be monitoring these people carefully. Their situation can change. Maybe their secretions start building up and they start having difficulty breathing. They can become septic and go into septic shock. We need to watch them carefully and frequently. Also, sometimes that oxygen therapy that they're on comes off and their oxygen saturation drops. So we need to keep an eye on them. Of course, treatment includes antibiotics, so we'll want to do that quickly. Monitoring oxygen saturations and administering oxygen as appropriate. We want to keep these people hydrated. Keeping them hydrated keeps those secretions loose and makes it easier for them to cough out secretions. Nutritional support is important. They need protein and nutrients in order to be strong enough to strengthen their immune system. They should be doing breathing exercises. If we can get them up and moving, that's great. It's important to balance exercise and rest for these folks. They may have activity intolerance due to hypoxia when they get up and moving. If the oxygen is not exchanging and the oxygen and CO2 are not exchanging across that alveolar membrane, then they can get hypoxic very quickly. So we need to be very sensitive. We encourage ambulation, we encourage movement and exercise, but we also encourage rest periods and positioning, therapeutic positioning. The goal is to help them to be comfortable enough to rest and to breathe easily. So make sure they're not scrunched down in the bed. You know how people with the head of the bed up slide down until suddenly it's the middle of their back, their chest that's crunched in the fold in the bed. So be sure people are pulled up in the bed properly. And then there it is again, pain management. People with pleurisy or pleuritic chest pain are not going to want to take those deep breaths that are so important to keep them healthy. And then let's keep the goals in mind. Effective respiratory rate, rhythm, and depth of respiratory. We want to help people breathe well, right? We want their lungs to clear up. That's the goal here. So coughing and encouraging incentive spirometer and perhaps suctioning is going to help with that. We want them to report that they are not in too much pain. We want their oxygen saturations to be greater than 95. Again, we want their lungs to be free of adventitious breath sounds. Please learn that word. Adventitious means not good. Adventitious. Those are the rails, the ronchis, the wheezes, the scary things that you listen for when you assess the chest. Adventitious breath sounds. And if someone is developing problems with a lot of sputum in their airway, we want to clear that up. All right, so we've discussed a little bit about the significance to nursing of pneumonia in terms of the fact that it is often nurse sensitive and we are responsible for preventing it. And then these are general principles for how you support somebody who's got issues with their lungs, any kind of pneumonia. And this would include people who are suffering from COVID-19, as well as our patients with good old-fashioned walking pneumonia. All right, I'll see you soon.